Hi, everybody. Hi, thank you all for coming. We really appreciate your attendance at our event. We are lucky enough to have Dr. Paul Rothman here today. So this is for the Ulster Medical Symposium. Established in 2018, the Ulster Medical Symposium is a student-run lecture series at the Johns Hopkins University. The symposium hopes to bridge the divide between those making decisions in medicine and those affected by those decisions. Providing a forum for speakers of diverse identities and experiences, we challenge the community to push the status quo in a direction that promotes health, equity, and justice. All events are free and open to the public.
Thank you all for joining this event, The Role of Economics, Equity, and Entrepreneurship, featuring Dr. Paul Rothman, the Dean of the Medical Faculty, Vice President for Medicine of the Johns Hopkins University, and CEO of Johns Hopkins Medicine. As Dean and CEO, Dr. Rothman oversees both the schools of medicine and the Johns Hopkins health system, which encompasses 6 hospitals, hundreds of community physicians, and a self-funded health plan. With that said, I'm really glad to introduce Dr. Paul Rothman.
Thank you. Well, good evening.
Good evening.
How's everyone doing?
Good.
So what? It's really I'm really thankful for being invited, and thank you for coming. What I thought today I'd like to do is just describe a little bit. First, I'll tell you about myself. I won't tell you anything about Johns Hopkins Medicine, but really focus in on this issue of healthcare disparities in Baltimore. Tell you a little bit about what the issue is and some things that Hopkins is trying to do to address it. I'm hoping to talk about 30 minutes or so, and then happy to take any questions that you have. So first, maybe be helpful to tell you a little bit about myself. I am the Dean CEO. I've been here since 2012. Just a little bit about my upbringing. I grew up in New York City. Went to public high school, to my college at MIT, where my greatest accomplishment was rowing crew, I think. But somehow I also did enough to make it to Yale Medical School. So I guess I did something along the way. And then after I went to medical school, I went to Columbia University. It was then Columbia Presbyterian Hospital, where I did a residency in medicine, a fellowship in rheumatology. I then went into a molecular biology lab and became a molecular immunologist, studying the immune system using the genetic manipulation of mice. And after about 20 years at Columbia, at which time I met my wife, who's also a physician. We met when I was an intern. We went ahead and took our 3 kids and moved to Iowa City, Iowa, where I became the chairman of medicine, and then the dean a couple years later, and then we moved here in 2012 as the dean CEO. So it's interesting when you think about going from New York City to Iowa City to Baltimore City. Baltimore is about halfway between Iowa City and New York City, not geographically, but culturally in some way, and in terms of some of the issues that we'll talk about today. Both Iowa City and Baltimore City are basically steeped in education. So Baltimore is a med and ed town at this point. Really focusing, it's sort of funkier types of towns, I would argue, and really focused in on what they do for their community. And we'll talk about a bit about that today. But we've been here. It's funny, we came and we have 3 children, as I said, and we thought they'd all leave. One actually only came with us, the other 2 were in college, and that one we thought would leave, but actually stayed in Baltimore. So we have 2 of our kids here, one in med school and one here as undergrads. Baltimore's been a good place. I ended up rooting for the O's. I'm from New York, because if you know you're from New York, anyone who beat the Yankees, if you're a Mets fan, is pretty good. So I've been able to root for the O's for my 6 years here. We've really engaged Baltimore as a family. It's really a wonderful city, and we really now call it home. That being said, we've really focused in on Baltimore in terms of our role in the healthcare providers and some of the problems with it. And part of that has to do with Mr. Hopkins. When Mr. Hopkins, for those who don't know, Mr. Hopkins gave 2 gifts. Mr. Hopkins gave a gift to begin a university and a separate gift to begin a hospital. And what he said of the hospital was that it would take care of all, regardless of their ability to pay or their race or their gender. And he asked us to really be of and serve the community of Baltimore. At the time they built the Johns Hopkins Hospital, for those who don't know, it was farmland, basically, up on the hill. With the poor part of Baltimore nearby, even back then, and it learned to grow there and really be of the neighborhoods that it was of, and of Baltimore now for the hospital has been there since 1889, and the med school, it's 125 years this year in medical school. For those of you who think our impact, though, Johns Hopkins Medicine has 45,000 employees. So if you think about what that means, T. Rowe Price, M&T Bank, Under Armour, Loyola, the Baltimore Sun, any one of those has less than 4,000 employees. So Hopkins is 45,000. Many of whom live in Baltimore. We probably think over 25,000 actually live in Baltimore City itself. Remember, when I talk about Hopkins, we have 6 hospitals, 2 in Baltimore, 2 in Washington, 1 in Howard County, and 1 in Florida, so that's all encompassed. So about 26,000 of them actually live in the city of Baltimore. So even though only about 600,000 people here, it's a pretty large part of the population. This sense of responsibility, I say, really goes back to what Mr. Hopkins asked us to do when he go to our hospital, and has been true ever since. I think, when we've thought about it, there are a lot of ways you can think about an involvement of a hospital and a health system in a city. And we've been, I say, taking care of people and trying to help the city for those many years. But I have to say, after 2015 and Freddie Gray's death, the tenure of and I think the impetus for us to even demorph this city, despite this long history, really was very evident to us. And we really took it upon ourselves to think about what our role is in our community and what we could do to help those of the have-nots in the city. And it clearly all haves and have-nots in the city. So what we did was we tried to engage, and we both engaged internally and externally. We had what we call a bunch of community conversation. And first it was internal to medicine. It's a huge place. We have 31 departments. We have 3,000 faculty just in the School of Medicine, so it's quite large. It's about half the entire faculty of the university, so it's quite large. And we had conversations, and it really came close that even within Hopkins Medicine, that in fact there were really not a wealth of communication between, for instance, physicians and staff. We weren't talking about what our lives were. And it really, I think, for many of the faculty, when you talk to people on the staff that lived in the city of Baltimore and try to understand their lives, it was really eye-opening for what they had to go through on a day-to-day basis. Similarly, what we decided to do is to really go ahead and engage the community. And we've had a series of conversations, both right after Freddie Gray, to really ask the community what could Hopkins do that would really help them. And subsequently, we have quarterly meetings in East Baltimore, engaging myself and other leaders with community members to try to understand what we could do. And out of all the things, and I'll talk about some of them, we really came away with it, but the lack of healthcare equality in the city was striking, and that we wanted to see what we could do to address it. And for those who don't know, Maryland is probably has the highest state income of any state in the country, but we ranked 33rd in terms of healthcare equity. So it was nothing to be proud of. The numbers are striking. If you look at infant mortality, and if you compare that to Roland Park, to someone who lives in inner city Baltimore, such as Madison East End, the infant mortality is 3.4 infant deaths per 1,000, 3.4 in Roland Park. It's 15.5 in Madison East End, so 5 times more. And that was a big improvement over 5 years before. If you look at life expectancy in Roland Park, which is not right over here, right, is 83 years of age. If you look at Upton, Druid Hills, anyone guess what's the life expectancy? So it's 83 in Roland Park, what would it be in Upton, Druid Hills?
Isn't that 65?
63, yeah. So 20-year life difference, 20 years. So, and that 63 is what you get to not even mid-level developing countries. It's actually to less developed countries. That 63 is pretty low. So 20-year difference with only 6 miles apart. So it was pretty drastic. So why is it true? What can we do to do it? So basically there's no one answer to try to address it. We've tried a couple of things. One of which is, we have vast amount of primary care in the community, but we said sometimes it's hard. In fact, if you look at people ask what's their biggest barrier for those who need health care, it's actually transportation. So we tried to distribute what we did already, even though it was concentrated in certain clinics. We did things like partner with Walgreens to do things like vaccinations in the Walgreens in East Baltimore, so folks didn't have to come into a clinic. We tried a lot to do things to just establish relationships in the community. Historically, one could say that the relationship between the Hopkins Hospital and the Hopkins Medical Center and its community at times would not be the best. So a lot of mistrust, to be honest. And so we try to do what we could do to try to grant that. And it's not good, we're not going to fix that in a year. We really thought this is a long-term project to regain their trust. What we do is we start community walks. So every month, myself and others, we do a walk in a different part of the community, and we tell the community partners along the way, it could be churches or schools, we're going to come by. We work with about 100 people out of Hopkins, just walk into our community and try to engage people and try to talk to them. We, again, have community meetings. We have them on some of our panels in the hospital to have community members participate in some of the decisions we make. And I think that's a big part of what we're trying to do. So that was just one outreach to begin. The other thing we came around with to think about is that if you are worrying about being evicted or paying the rent or getting your next meal, it's really hard to think about the best way about the food pyramid and whether you're having 5 to 7 servings of fruit and vegetables every day. And so we thought that we had to do more than that. So when we talk about healthcare disparities, we tend to focus on the environmental factors that lead some groups to have far better health than others. But there's also a problem with the quality of care that one gets, which is different, right, than just access. The country's addressed that in many ways. If you go back, things like Medicaid, now expanded Medicaid after the Affordable Care Act. The Children's Health Insurance Program, CHIP, which you've heard a lot about in the age. Those are some examples that the country has tried to do to ensure that everyone gets a level of care, but these disparities still exist. I'll give you an example. So Amanda Fader, who's one of our OBGYN, did a study where she asked the following question. If you're having a hysterectomy, in the old days what you used to do is you used to slice open and you take out the uterus. And that was the way we did it for decades. What we now do is we do a much less invasive way to do it. We can either do it laparoscopically or by robotics and have a much smaller scar. And with that, there are better outcomes and people have less pain and they get out of the hospital quicker. And so it's a standard of art. If you look at Hopkins Hospital here, 90% of the women who get hysterectomies do it either laparoscopically or by robotics. What Amanda did about across 45 states and asked, what is the likelihood that someone's going to get this minimally invasive surgery versus the classic total hysterectomy? And the data look like the following. If you were Black or Hispanic, you were less likely to get the minimal invasive surgery. If you were on Medicaid or uninsured, you were less likely to get the laparoscopic and non-invasive surgery. So that shouldn't surprise any of us, but in fact, it was true. And if you look across a whole range of healthcare outcomes, such as premature heart disease, it's 50% higher in African Americans than it is in whites. And you can find that against many different types of healthcare. And to remind us that Martin Luther King said, of all the forms of inequality, injustice in healthcare, the most shocking, of all the inequalities, injustice in healthcare is the most shocking and inhumane. That's a tough pill to swallow in a society like ours that has a lot of money. So we decided to say, can we ensure that everyone who's seen in the Johns Hopkins Medicine Hospital gets the same care regardless of race? So I asked that simple question, can we address that question? And the answer is we couldn't even look at it because we weren't keeping data on the care we provided by race. And so we spent a year now to ensure that every one of our Johns Hopkins hospitals includes that in how we look at the measurements of care that we provide for people. So moving forward, we're going to be keeping that data. We didn't even have the data. So now we have to go back and say, okay, can we ensure at every one of our hospitals, and we're committed to it, that that's going to happen. We also looked at our clinical research that we did, and we found, in fact, we had some disparities of the enrollment of African Americans to whites, and I'll give you an example in our cancer center. So in 2010, when we looked at the enrollment of our clinical trials in cancer, and we looked at African Americans versus whites, we found that only 12% of, only 6%, 12% of the patients in our clinical trials were African American. This is in Baltimore. Anyone know what the African American population is as a percentage? It's 60%. So although the city was 6% African American, only 12% of the patients in our cancer center clinical trials were African American. We said, well, why? Well, why is it so low? Because certainly if you look at patients in our hospital, it actually reflects the communities that we take care of. And we started asking that question, and what we found was that it had to do with transportation. The people who are in clinical trials have to come to the hospital much more often, and they couldn't afford to get to the hospital to participate in clinical trials. Well, for us, that's an easy fix. So we started to pay for the transportation for patients enrolled in cancer center clinical trials to come to Hopkins, and we've doubled the percentage of enrollees who are African American in just 2 years. So just one way you can start to think about ensuring that care is provided regardless of race. When we think about social determinants of health, there's a lot more that goes into it. There's a great quote from a Nobel laureate called George Wald, who's a chemist, but provided the following quote: "The trouble with living with contradictions is that one gets used to them. The time has come when physicians must think not only of treating patients, but of trying to help heal society. If only so that their work is not incompatible with surrounding circumstances." So what he's trying to say, and I've worked in inner city hospitals, 20 years at Columbia and now 6 years at Hopkins. If you're in an inner city hospital, you see a lot of poor people. You understand that they get sick. Many of their illnesses are related to the poor socioeconomic circumstances surrounding their lives. But as a doctor in a hospital, you're just so caught up in taking care of patients that you take care of them and you send them out. What Wald is saying is that's not enough. That if you know that some of their poor health is due to their poor circumstance, you need to start to address that as a profession. That not to do that is just incompatible with what you want to achieve, which is the health of your patients. So if you break that down, it's complex. Poverty is a vicious cycle in inner city communities, certainly has been here in Baltimore for decades. And so what can you do to start to address it? Well, we'll do a couple. Let's talk about just several. These are not inclusive of some of the things that cause poverty in Baltimore. Let's talk about mental health. Let's talk about addiction. Let's talk about employment opportunity and enhancing education. Those are not the only reasons people are impoverished in these vicious cycles, but certainly one would argue that they're important. So first of all, mental health. Mental health in this city is a huge issue. The data looks at from 1 in 5 residents in Baltimore, 1 in 5 experience a mental health illness every year. 1 in 20 has a serious mental illness such as schizophrenia in Baltimore. If you go around, many of these are untreated in jail people, which is a lot of them end up being in jail, and a lot of them end up turning to illegal substances to self-medicate. They have trouble holding down jobs. They have trouble keeping stable housing. It also can lead to trauma for their children. You know, we had an awful case this year that most of it was in the press. We had a 14-year-old boy who came in for surgery. His parents were there. They sent him to the emergency room. The parents had a fight. The wife ended up stabbing the husband right in and killing him in Hopkins Hospital. Obviously, there were some issues there that hadn't been dealt with for years. And so when you think about that kid who now comes back into after surgery, who was going in for probably a pretty scary event for himself, comes out and his dad's dead and his mom is now in custody. So think about the trauma that person now has, and that trauma that our kids have in the city with all the violence there is not just isolated to this one child, but it's true in many of our most vulnerable communities because of the violence inherent in those communities. So we have a big problem here in the city in terms of mental illness and the support for that. That is not an easy issue. We're trying to provide as much service. There's a broad issue here in healthcare. There's a broad issue from most states, including Maryland, that have basically walked away from the facilities they used to run for chronically mentally ill people. What we're trying to do is try to get our mental health out of the hospital setting into communities. We just opened up a 75,000 square foot community psychiatric hospital at the Bayview campus. That's not an inpatient, that's for outpatients. So they can stay in their home but receive the care they need. There's a program we opened this year called Teen Testimonies for Latino students in Baltimore City high schools that have trauma, and we have counselors then that can actually help counsel them in Spanish. Again, something that we try to do. So I think we have a long way to go. At Hopkins, as big as we are, we can only scratch the surface and provide what we can provide, but I think as a society here in Baltimore, we have to address a mental illness issue. The second big problem we're going to have is addiction, opioid addiction, huge problem. Has been a huge problem in Baltimore since the 1960s. This is not new. It's interesting. I spent most of my career at Columbia in New York. New York City transformed from a heroin city to a cocaine city and crack cocaine in the 80s. And only most recently has gone back to a heroin city. Baltimore never went to a crack cocaine city. It's been a heroin city now since the 1950s. And it's interesting, I gave a talk this morning, it's now become more of a focus nationally is because that heroin addiction, which really was an inner city issue, has now moved out to the suburbs. And you're now seeing it much more in the press than it ever did. Right now, in Baltimore, there are 2 fatal overdoses every day. 2 fatal overdoses every day in the city of Baltimore. Nationally, drug overdoses, there are more people who die in drug overdoses and car crashes and guns combined. Think of that number. It's really pretty astonishing. Again, there's a lot to do. Actually, Hopkins leads the way in studying drug addiction. Our drug addiction is out at our Bayview campus. For those who don't know, the National Institute of Health have their Drug Addiction Institute also at the Bayview campus. So it's a national area of study for how we can affect opioid dosing. In our hospital settings, we've done a lot to decrease opioid prescriptions because part of this issue is the overprescription of opioids. We've done a lot to protocolize giving people minimum or no opioids if possible, especially then. And then we've really thought about naloxone, which is Narcan, which is the drug that can prevent you from dying from an opioid overdose, and tried to do that. And most importantly, we're teaching our medical students a lot about treatment and prevention of opioid addiction. Again, something we can't singularly treat at Hopkins, but something we think we can help others do. The next problem, I'm going to keep time, is the problem of employment. So if you really think at the heart of poverty is people don't have money, right? Why don't people have money? Well, in Baltimore, it's a more complex issue. So Baltimore, like many of what are called Rust Belt cities in this country, was a manufacturing city. For those who you don't know, probably none of you were around then, I wasn't around then, this city really manufactured cars and steel. There's a large General Motors plant here, a large Westinghouse Steel plant here. If you look at 1970s to today, there are 60,000 less manufacturing jobs in the city of Baltimore over that span. Those jobs were for people who they didn't require college education. There were people who could come in with less than college education. Those jobs are gone. And the ability to get reemployed is, for that generation of people, is a real issue. And it goes together. So again, if you can't get a job, you live in poverty, that leads to crime and drug addiction and other issues. So when we went out to the community after Freddie Gray, we asked, what's the best thing Hopkins can do for you? They said, jobs. We need jobs. That's what you can do for us. So we've tried to do that in many ways. First of all, the health system and the university together did this thing called Hopkins Local. Do you guys know what that is? Where we made a real commitment to hire folks from the distressed areas of Baltimore. And we set specific goals to say that we increase our hiring, and after year one, our goal was, and we hit our goal of 300 people from distressed zip codes that we're hiring at Hopkins, both the health system and university, from those distressed zip codes. I'll give you one example. One, a guy named Clayton Smith, 55-year-old, was a trucker, lost his job because of change in the trucking industry. Then came to work at Hopkins Hospital as a linen worker, then a patient transplant. Now he's a supply equipment coordinator. So these are really talented people that just need a different mode of employment than they used to have in the old way. There are a lot of other examples I won't give you here. In addition, we said not only do we want to employ people, but we want to make sure that we can help businesses that can grow here in Baltimore so that others can hire more people. So we've committed to something called Be Local, where we've committed to increasing our sourcing of our supplies and other things from people based here, from businesses based here in Baltimore. We then asked, and we went to our trustees, many of which are businessmen in Baltimore, and said, can you help us? So we got 25 local businesses to join with us in what's called Baltimore Local, which is agreed with the same thing we'd agreed to. Hire more people from distressed neighborhoods and invest more of your supply type of expenditures in Baltimore businesses. That's how we have to do it. We have to really, from a very roots level, get people employed here, get people jobs throughout, especially in those bad neighborhoods. Our final thing is what we did is in ex-offenders. So 6,000 people every year leave jail and come back to us in Baltimore, 6,000. There's a very high recidivism rate of those folks. And we said, well, can we do something to help that? So now for 10 years, Hopkins Hospital has been the leader in hiring ex-offenders to work at Hopkins Hospital. We average 125 a year, far surpassing almost everyone else combined in the city of Baltimore in terms of hiring ex-offenders. We obviously, most of them are nonviolent offenders. We have special programs to reorient them and get them ready for jobs here, and it's thought to be one of the biggest successes that we have. Finally, in education, I'm going to stop so you all can ask some questions. So what we did is we have to do a lot of things to try to help the young folks in the city, the students, to really grow and thrive and get the education they're going to need for modern jobs in this millennium. So Doug Robinson, who's a cell biology professor, very successful, well-funded, said, I want to do more for the community. So he set a program up called SARE, which is Summer Academic Research Experience. I think it's up to 100 students a year come to Hopkins. We pay them. They come, they learn about science. We teach them skills they otherwise might need for the next stage of their schooling. And so far of this program, 100% of them who have reached college with age have matriculated into school, into college. So we're pretty proud of that. We also help with P-Tech, which is a program at Dunbar High School where people are tracking. You enter Dunbar High School. It's a 6-year program for Dunbar to the community colleges, and the health system guarantees them employment. And not a minimum wage job. These are people that are gearing up to be laboratory techs in the operating room and around Hopkins Hospital. So again, it's a really ground roots effort to get young people into jobs here in the city of Baltimore that will lead to full-time employment for a long time and help bring them out of poverty. So I have a lot more, but I wanted to answer questions. So as you can see, we're doing a lot, but we have no thought we're going to solve this issue by ourselves. what we hope to do is pilot as much as we can and help others in the city join us in this quest to raise Baltimore up, especially those impoverished, to ensure that they have jobs, they get the type of education that will lead to jobs in the future, and those that come into our health system get the same care as everyone else, and to ensure that they're treated with the respect that we would treat everyone. So thank you for your time, and I'm really here to answer questions or hear anything else. So.
5-minute break, we just gather our questions then.
Okay, 5-minute break, and we're going to get the questions. Sort of about how I moved from being a researcher to administrator, I guess. So I wish I could tell you that I had this wonderful, purposeful plan, how I had outlined my entire existence and how I had plotted out what I needed to become dean of a medical school. But I had no idea I'd ever do this, to be quite frank. So I'll tell you my story, which is different, probably going to be different from any of your stories, if you want to sort of do something like a high-level hospital administrator, because it's become more complicated. So I just ran a large research lab. I had millions of dollars of grants and lots of people and turning out really good science, and people thought that I had the skill to do something more, and they just asked me to do it. And I hadn't gotten an MBA or taken a business class or anything like that. I just ran a big lab, and people said, well, why don't you try to be this division? Found a division. I actually built a division in Columbia, and I did it and successful. And then the next job came, and I was successful. And then the next job came, and I was successful. So what I sort of tell students is, and actually even my kids, the best way to get the next job is do great at the job you're doing. So quite frank, so a lot of people think this great trajectory of their careers, and it's almost never straight. And so my only advice to you is whatever you want to do next, just do really well at what you're doing. And then they'll come looking for you. That being said, that was the old days. Now it's the new world. If you really want it, so medical students always ask me, do I need an MBA? I want to be a high-level hospital administrator. At my age, you didn't. And today you probably do, just because it's, and we could have the discussion of whether or not you get skills to get an MBA that you otherwise couldn't attain. I'd probably argue you don't, but in today's world you need to check the box. So I think if you really want to do it, you probably have to. Is that like Freebird or something? I did not do that. I was, did someone in the back maybe lean against the light in the back?
Yeah, did someone push this switch? This is the first time.
How about opening the door for that lighting? That might help. There you go.
We could all flash lights.
There you go. You guys didn't get the free program. At a constant. So, and so I think the road requires a little more purposeful, but still that general comment, just do great at what you're doing. That's what I look for. I look for people who've been successful in whatever they're doing. And then you go and get the next job.
So what plans does Hopkins have to alleviate poverty in the Baltimore community?
I'm sorry, what?
What role does Hopkins want to play in the future to alleviate poverty in the Baltimore
So
community?
the question is, what role does Hopkins want to play to alleviate poverty in the community? I don't think we have any notion that we'll eliminate poverty in the community. As I said, I think we want to do the best we can. We are the major employer in the city. We want to use some of that money. You know, Hopkins Medicine, so all our campuses, we have $8 billion in revenue and pretty much $8 billion in expenditures. So we want to basically help leverage that to do things like buy more in the community, just try to get the community more vibrant in terms of economic activity. And education, I think, those are the big things we look at. Helping people out there who can't get jobs now, and then make sure that the next generation doesn't recapitulate this cycle of poverty that we see here.
So I remember you were talking earlier about there's an issue that a lot of the elderly patients that are coming in, right, they often aren't taken care of properly just because doctors are so busy in trying to make sure that they're able to take care of the patient at the moment and then sending them on their way back into the community. So does Hopkins have any plan, or is it working on something right now currently to connect these elderly patients with resources outside, with maybe local clinics that can take care of them on a long-term basis?
Yeah, so it wasn't quite what I said. What I said was all patients. We're just so busy that we take care of sick people who come. And
Often.
in the past, we have not thought as much about what happens after we discharge them. That world is really changing. For those of you guys know that the payment system here in Maryland, so Maryland's got a healthcare payment system different from every other place in the country. So in Maryland, it's a really interesting. So in Maryland, every payer pays the hospital the same amount of money for the same procedure. So let's say you want your gallbladder out, a cholecystectomy. If you're on Medicaid, or if you're on Medicare, or if you're on private insurance, Hopkins Hospital gets the same amount of money for that same procedure. We're the only state like that. It's a rate-regulated system, so there's a state agency that sets the rates at every hospital in the state. If you think about that, for those of you who don't know, any other state in the country, government payers, Medicare and Medicaid, do not pay the true cost of care of government patients in hospitals. So in New York City, where I was, Medicare pays about 90 cents on the dollar of the true cost of care for a Medicare patient in New York City. A Medicaid patient, the government pays about 60% of the true cost, maybe 75%. When you're talking about hundreds of thousands of patients, that ends up being a lot of money. So in every other state in the nation, that's true. In Maryland, it's the only state in the country where the government actually pays the true cost of what a government or Medicare Medicaid patient costs all hospitals. If you think about it, that costs the government a lot more money in Maryland than it does in other states. So they started to say, we need to bring down that cost. And so starting next year, all the hospitals in Maryland are going to be responsible for what's called the total cost of care of our patients. So we're going to have skin in the game to ensure that the total cost of care of patients, Medicare and Medicaid patients in Maryland, decreases total care per year. If you think about that, that requires us to think about what happens to Medicare and Medicaid patients out of the hospital. If not, we're going to have to give back money if the total cost of care goes up and doesn't go down. So for the next several years, we're going to be very focused on what's called population health, thinking about the total health of those patients, not only when they're in the hospital. We began that actually 3 years ago. We got a large grant from CMMI, $21 million grant, to ask if we can bring down the healthcare costs of patients in the seven zip codes around Hopkins Hospital and Baylor Hospital. And we actually saved Medicare and Medicaid $90 million over 3 years in the cost of care for Medicare and Medicaid patients in the 7 core zip codes around the hospital. We're going to have to actually increase that over the next 5 years. So we're going to be really thinking about what happens to those patients outside of when they're in Hopkins Hospital.
So building off of that in terms of population health, what partnerships is Hopkins currently considering, either with organizations in the community to kind of bridge that continuum of care after they leave the hospital?
So that's a great question. So what partnerships? And clearly, so I'll tell you the story about this J-Chip grant we got. First year in, we did what we always did. If someone got discharged, we had a nurse from the hospital call the patient. We had nurses from the hospital visit the patient. They didn't answer the phone, and they didn't answer the door. And we said that this probably isn't the way to go about it. How are we going to engage these folks in their homes outside of Hopkins Hospital? So what we did is we went to the churches around our hospital, and we asked them if they could help us. And we began partnerships with churches. And the partnership was, you bring us people, we'll train them as community health workers. We'll employ them. And then they need to work with us to coordinate care of patients in the community that we see at Hopkins Hospital. That's when we started to get doors answered. That's when phones started to get answered, but it wasn't us, but their friends in the community, many of which were also went to the same churches that they went to. As we go the next several years, we have to enlarge those partnerships with community groups and hire community healthcare workers to help us reach these people in their homes, because they're really the trusted agents in the home more so than we are. So we're doing it. It's going to be a journey, but we're trying.
Yes, so lots of the issues you've mentioned are faced by many of the major cities around the United States. So what makes the situation in Baltimore unique?
So why is this? 343 murders, highest in the country. Baltimore has a lot of historic things. Again, New York City is very different. We have a level of poverty here that I think is higher than many cities. We have, I mean, let's face it, we have a history of racism in this country that began with housing, but is, you know, we are a southern city, some of them, and a long history that I think is not good. So you add this loss of manufacturing jobs, building on this cycle of poverty with an underlying of violence and racism, it's a unique problem. Not unsurmountable, but certainly nothing we're going to fix in a year or two.
Hopkins has made a huge commitment to stay here. We built our new hospitals with this commitment to stay in Baltimore. And for us, we are Baltimore. It's our folks. We have to fix the problem. We need a good government leadership to join us in partnership. And we like Catherine Pugh. She's been terrific. And we're hoping to just build those partnerships. So.
Is Hopkins building partnerships with other health systems that might have been in similar situations?
So we do have a couple of partnerships. We have a partnership with Allegheny Healthcare in Pittsburgh. They need our help in some things like cancer. We have a partnership with Kaiser Permanente, trying to learn from each other. We have smaller partnerships with others, but I think those are the two big ones. Are we going to build more? You know, Maryland's pretty consolidated healthcare. There's really only 3 large systems in Maryland, which is us, MedStar, and Maryland. The DC is, Northern Virginia is dominated by one health system, and over DC has MedStar, us, GW. So there might be a little more consolidation. They're fairly consolidated, but there are still a couple of independent hospitals that might get sucked up. And potentially there are larger partnerships we'll do, but none that we're ready to talk about. One more question. How to get into med school? So let me just tell you that, how to get into med school. Work really hard, do really well. No. So I'm just saying the numbers, I don't want you to get too discouraged. First of all, I was asked today, I was interviewed, would I go to medicine today? Absolutely, do it again. Doesn't mean it's easy, but it's my life, it's my passion. Hopkins Medical School is pretty tough to get into, so don't be discouraged. The numbers look like 6,300 applicants last year for 120 slots. The average GPA is 3.91, that's the average. And she, MCAT average was 519, or 1519? Yeah, 519? 519. So we were the highest, I think, of any med school for MCATs. And with that, we rejected a ton of kids with those numbers. And we accepted, so think about it this way, you know, that's the mean, so half the kids had less. Great. What you need to do is, and this is for any med school applicant, is you need to demonstrate to us that at Hopkins, Hopkins is a unique resource. It's the top medical center in the world. You need to demonstrate to us that somehow you're going to leverage that to make an impact in the world. Because we probably have 500 people just like you who want to get in. And so we want you to show that you're going to use this unique resource to do good. How you do that, you can do that a lot of different ways, right? But you have to really convince us that you're going to come here and do something special. One last question.
I just have a question. So Hopkins is well known also for its research and school of public health. Do you think that they have a role to play in affecting the city and the community's health also?
So absolutely, almost everything, first of all, the opioid stuff, almost everything we do is in partnership. I think a third of the faculty in the School of Public Health are also faculty in the School of Medicine. So we have a very tight partnership, and the School of Nursing, which is also #1. So the partnerships there are very strong. So the School of Public Health has a ton of programs to help the city. I just focused on what medicine does in the ways that things that we're doing. We have I think a little more resources to do some of the employment stuff and the buying than a School of Public Health do. They do a tremendous amount in the community partnering with folks, but their focus is a little different. They probably run more programs than us in terms of inner city programs. So, you have one other question? Okay, I'll be here in a couple of minutes. People will come up and ask questions.